Wow, thanks a lot. That was great. I appreciate the intro. Yeah, so my name's Adam Kuchnia, and like Christina said, assistant professor here in the Department of Nutritional Sciences. And I'm also an affiliate faculty in the Department of Radiology, and I kind of joke that that just means that I'm not a radiologist, and I get to work with a lot of brilliant individuals in the Department of Radiology, which really I utilize in all my research, right? And so today we're going to be chatting about age-related decline in muscle and function. So we'll just jump right into it here. So, yeah, broadly speaking, like Christina said, my research really focuses on really everything muscle, right? And so my research touches on malnutrition, cachexia, frailty, and sarcopenia, and what happens, as we age and as we have disease when we lose muscle mass and when we start to waste, right? For the purposes of my talk today, I'm really going to be obviously focusing on sarcopenia. And the thing that you need to know is sarcopenia is really interconnected with all these different wasting syndromes, right? And if an individual has sarcopenia, it's just going to put them at risk for these other detrimental items as well. For my research and on my typical day-to-day, my research primarily focuses on cachexia. But again, sarcopenia there's a lot of interesting overlap with that. And I do want to say that I, kind of informally split my talks between muscle mass and then this other section that I call muscle quality. And so I'm going to start by talking about muscle mass and our traditional thought of muscle loss as we age. And then I'll go into some more of the muscle quality attributes here later down the road here. So just very basic, right? What I want to do is provide a little bit of an introduction of what sarcopenia is, right? Why do we care? Traditionally, how do we identify it, what we're doing to say something a little bit more meaningful about muscle, and then if we have time, talk a little bit more about the management of sarcopenia, right? And so right off the bat, muscle loss starts around the fourth decade of life, right? And it decreases by 3 to 8% per decade after the age of 30, 1 to 2% per year after the age of 50. And in that age range from about 20 to 80 years, right, we lose about 30 to 50% of our muscle. Right. So that's not insignificant, right? And so if you're looking at these pictures, these are cross-sectional areas of the thigh by way of CT. You can see this 23-year-old and the 71-year-old, and things look very different, right? Not only from a mass perspective, right, in a cross-sectional area, but you can also clearly see that we have some infiltrates that is kind of filtering into the muscle itself, which we're gonna touch on. Okay, so there's some drastic changes that are occurring here. And it's traditionally thought, and established that the decline in the mass, the muscle mass, is mainly due to a reduction in our type 2 muscle fibers, right? And so then if you're looking at this image, our type 2 fibers are glycolytic fast twitch fibers, right? And as we age, we tend to become more dominant in type 1 fibers. We lose those type 2 fibers, right? Those fast twitch. And you can see on the picture here, we have our type 2 fibers that are large and they're black, right? Our type 1 fibers, our oxidative slow twitch muscles are red. And what you're seeing is a young individual on the left and an older individual on the right. And you can clearly see that, well, the loss in the cross-sectional area of our type 2 fibers is pretty drastic, right, as we age. And for the most part, our type 1 fibers are somewhat conserved. So getting into the basics of, okay, well then what is sarcopenia? What is this loss of muscle mass? Well, sarcopenia is then formally the age-related loss of muscle mass and function, right? And it is, one of the most consequential changes associated with aging, and it's extremely pervasive and costly, right? And it affects about 10 to 14% of older adults, and it's rising, right? Because we're an older population, and it's currently estimated to cost almost $20 billion annually, right? And that's not a little amount, right? And you can see on that chart on the right where it's actually blocked because of some pictures on my screen, but what you can see is, it's estimated by the time we get to 2060 that about 25% of the population is going to be over the age of 65. Right, which is only going to lend to this increase in sarcopenia and the healthcare burden and emotional burden that this comes with. And like I said before, sarcopenia is a major determinant of frailty. Frailty is kind of this composite measure and score that just generally refers to somebody's vulnerability to daily and life stressors, right? And we can kind of clearly tell in the back of our mind if somebody looks frail or not, just by the way that they move, walk, stand up out of a chair and things like that. And that's, again, associated with very poor outcomes. And then sarcopenia also results in a lot of metabolic consequences, right? Unfortunately, what I do want to touch on is that there is no FDA-approved pharmacologic aimed at mitigating or controlling sarcopenia as we age. And I think at this day and age, there's a lot of interest now in these GLP-1 agonists and things like that are trying to get at this, but there's still no approved pharmacologic, which is probably why, to some degree, the field is being held back and languishing a bit. We can, and I'm not going to perseverate on that right now, but I'm very happy to take questions later. And so what are the consequences then, right? And so we see an impaired ability to perform activities of daily living, right? And functional impairment, which leads to reduced quality of life. And then we have this loss of independence. We have a falls or fear of falling, right? Which then these lead to individuals who are going to fracture, increase healthcare costs, and death, right? What you're looking at on that chart on the right is a Kaplan-Meier survival curve in 770 patients that were admitted to a hospital. And it's looking at their survival in the year following discharge. And individuals upon admission that were diagnosed as sarcopenic, at 1 year following, those individuals, 26% of those individuals had died, whereas individuals who were non-sarcopenic upon admission, 14% of those individuals were, or 14% of those individuals had died a year later. And so you can see the discrimination between those two numbers, right? And these were, the hazard ratios were also very much controlled for other very prognostic clinical measures in these individuals. So we can see that it does lend significantly to reduce survival. And so then elaborating a bit more on the outcome of falls and fractures. So sarcopenia is also the strongest predictor of falls. Right. And so then looking at this table on the right, you can see the odds of falling was highest when someone was diagnosed with muscle weakness or sarcopenia. And the second highest was history of falls. Right. And it's been shown that greater than 30% of adults over the age of 65 years fall each year. And then greater than 40% of individuals age 75 years and above fall each year, excuse me. And falls drastically increase when over the age of 80 years of age, right? And so it's also been shown that falls are the strongest predictor of fractures in older adults, right? Not low bone mineral density, right? Although low bone mineral density is important, falls are the strongest predictor of fractures. With fractures being, why do we care about somebody falling? Well, it's because they fracture. And it's not just, like a broken bone, right? It's no big deal. They can get a cast. It's not that. It's this entire inflammatory cascade that is lending to reduced survival. Of those falls in these older adults, 10 to 15% result in fracture, and over 90% of hip fractures are due to falls, right? And so just as a side note, the U.S. healthcare system spent upwards of $19 billion on direct medical costs for fall-related injuries. Right? And hip fractures alone cost $9 billion per year. Right. So this is not going down, right? It's only going up. And the reported 1 year mortality after sustaining a hip fracture is about 25 to 30%, right? After the age of 60. If you're older than the age of 60 and you break a hip, there's a 25 to 30% chance you do not make it out of the hospital. Right. So again, just pointing to the fact that these falls are extremely consequential because they lead to these fractures that are life-threatening in older adults. So, when we're talking about muscle loss and aging, it's due to a broad spectrum of stressors that can result in a slight and prolonged negative protein balance. Right? These signaling pathways result in the activation of various transcription factors that ultimately lead to changes in the rate of synthesis and breakdown, right? Some of these stressors are hormonal decline, right? Which I keep hearing nowadays, TRT, testosterone replacement therapy, right? And men who are losing testosterone, women who are losing estrogen, right? There's increased inflammation as we age, IL-6, TNF-alpha. This increased inflammation does have detrimental response on protein synthesis. And then a lot of older adults are nutritionally deprived, right? A lot of them suffer from malnutrition. And when we're talking about malnutrition in older adults, we're really honing in on protein, total calories in general. And then also there's some interesting research by a colleague of mine talking about, why vitamin D is so important in this whole picture. And then we also have decreased neuronal activity, right? We have decreased motor neurons and their ability to fire, decreased mechanical loading, right? So we're not as active, we're not working out as much, we're more sedentary. We have increased oxidative stress, like mitochondrial dysfunction, which I'll touch on a little bit later. And then we also have comorbidities, right? We have an increased disease, which lead to this inflammatory cascade and this uptick in the protein breakdown. And so it's this prolonged kind of skewing of protein breakdown that is just going to cause then sarcopenia. So I'm not going to perseverate on this too much. I'm really not. But for those of you who are interested in signaling pathways and potentially therapeutic targets, right, for protein synthesis and breakdown, here it is for you, right? And so again, sarcopenia is the result of this slight prolonged negative protein balance. And so, few pathways have been shown to control protein synthesis, right? But for the most part, they all converge at insulin-like growth factor and the AKT-mTOR pathway. Not all of them, but it's well known and well established that a lot of the protein synthesis converges through that pathway, right? And so this pathway is interesting that it can simultaneously suppress a lot of the muscle breakdown pathways, which include the ubiquitin proteasome system and then autophagy as well, by way of the phosphoramidite transcription factors, right? So it's really interesting that way. And mTOR in itself is comprised of two different protein complexes, mTORC1 and mTORC2, which are not on this slide, and I don't really mean to get into that, but mTORC1 is really the complex that's critical for muscle hypertrophy induced by exercise, feeding, growth factors, etc. Right. And then what I didn't say before is I think, some of the power in this presentation are my citations. Really pull these citations, take a look if you're interested in anything a little bit more in depth. But, sarcopenia, unlike cachexia, sarcopenia is characterized by a low smoldering inflammatory process, right? Triggering muscle breakdown signal, right? This becomes increasingly important in older adults with increased comorbidities, like we said before. It seems like aging nowadays is, we're just going to have these comorbidities of heart disease and things like that, right? Which is going to exacerbate the inflammatory cascade. And again, this is a very complicated and complex picture, but really for the most part, I think a lot of people know that, we think of reactive oxygen species that accumulate throughout our lifetime, and then, it increases the it converges in the NF-kappa B signaling, which then exacerbates and upregulates the ubiquitin proteasome system and autophagy, skewing it towards protein breakdown, right? And then also kind of the classical model of aging is mitochondrial dysfunction. But when you think about, mitochondria are the largest producers and lenders to reactive oxygen species in the body, right? And as we accumulate those reactive oxygen species, it's thought that damages and mutates mitochondrial DNA, right? Which then produces dysfunctional subunits of the electron transport system, right? And then just exacerbating that vicious cycle, right? So there's a lot of issues pertaining to mitochondria when we think of aging. But getting into kind of the more didactic portion of this talk, right? We have how do we diagnose? What's a traditional diagnosis for sarcopenia? And there's a few different diagnoses that are used, but one of the most common is from the European Working Group, and it was revised in 2019. And how we diagnose is by, an individual will have probable sarcopenia, right? If they have low muscle strength. Right? Now if somebody has probable sarcopenia, you do further testing, right? And so then sarcopenia is confirmed if they have then low muscle quantity. And then also within the definition, it says or quality, although, we do not have any consensus on what these biomarkers of quality are that I'm going to talk to you about a little bit later. So really, it's just confirmed with quantity, right? Primarily with DEXA or dual energy X-ray absorptiometry. And then, we have severe sarcopenia if we have low physical performance on top of that, okay? And so then how do we measure strength, quantity, and physical performance? Well, depending on what definition you're going by, it's going to be a little bit different. But if we're looking at the European Working Group, right, we have for low strength, we have grip strength, chair stand. For low muscle quantity, and really all of these groups, we are looking at DEXA measured lean mass, okay? And oftentimes we will do a summation of the bilateral arms and legs, and we index it or normalize it to somebody's height, which is the kind of the verification of sarcopenia. And then for physical performance, we can do gait speed, timed up and go, 400-meter walk test, things like that. Now, there's a number of problems with this framework that pertain to really DEXA imaging, lack of muscle quality biomarkers, and these volitional tests of strength and function, right? The latter being limited by illness and motivation in individuals, right? And there's also some issues with DEXA, and really the volitional strength measurements that lends to a lack of, right now, there's no, like I said, there's no FDA-approved pharmacologic for sarcopenia. There is for, osteoporosis, which some think it's a similar pathology in different tissue, but that's because DEXA does a really good job at measuring bone and bone pathology, whereas it doesn't say anything about, or it says very little about skeletal muscle, rather it talks about lean mass, okay? And I'm going to get into this issue here on the next slide, but I'm more than willing to chat more about the intricacies of DEXA pertaining to sarcopenia assessment. So DEXA measures, like I said, lean mass, and it may present challenges estimating muscle in older adults. And when I say may present challenges, it does present challenges if we want to say something specifically about skeletal muscle, right? And so this slide and this study by Neil Binkley and Diane Krieger, this kind of illustrates my point, right? So what you're looking at here, this is a really simple study that they did in a handful of older adults, right? And basically what you're looking at on this XY chart is we have, as individual, the proportion of lean mass contained in the head is negatively correlated with total body lean mass, showing that the greatest head lean mass was in those with the lowest amount of total lean mass. Okay, so just individuals that had a lot of muscle up here had the least amount of muscle down here, right? And so then it's plausible that as we see these changes that are occurring in the body and the brain, right, that we tend to retain fluid within the brain, that DEXA is reading that as lean mass, right? Whereas it's probably just fluid. And we've seen the similar thing that if we put a saline bladder on somebody's abdomen and we run a DEXA scan, most of that comes up as lean mass, right? Similarly, if we have individuals with lower body edema, that shows up as lean mass, right? And that's going to skew the measurement, right? Those individuals very well might have very low skeletal muscle, but because of all these confounding, the retention of fluid, the relative shift in the extracellular fluid from the intracellular fluid that we see in older adults, it's going to skew that lean mass measurement. And that's one of the problems that a lot of these different working groups have with DEXA, and somewhat disengaging themselves from utilizing it as a primary diagnostic measure for sarcopenia. But at this point in time, we really don't have much else, right? So I'm going to get off my soapbox on that for a little while. But I mean, DEXA diagnosis is somewhat plagued by kind of hitching itself to DEXA, which is why more working groups nowadays and in the past few years are really looking at muscle strength rather than muscle mass or lean mass by DEXA. And that's because of some of the work that came out in the early 2000s and more recently that showed a decline in strength and power precedes and occurs more rapidly than the loss of muscle mass with aging, right? So this chart on this bar chart on the left is a really classical study by Brett Goodpaster in the early 2000s, really shine light on this. And what he did is he looked at almost 2,000 older adults in the Health ABC study, right? And he found that rates of leg strength decline were 3 times greater than the rates of loss of leg lean mass, right? And so then muscle quality, this is where I'm getting to my muscle quality portion of the talk, right? So muscle quality is traditionally defined by the strength per unit size of the muscle, right? And it's typically used to describe the discrepancy between the loss of mass and the precipitous loss in strength or function, right? And so then we have our muscle quality parameter. right? And this muscle quality parameter is highly associated with a slew of poor outcomes, well beyond that of mass alone, which is why my interests primarily revolve around muscle quality, right? More recently, there's a really nice review here that I'm citing in 2022 by Grosicki and Chris Sundberg out of Marquette that really showed, actually, move something on the screen. So, which showed that the reduction per year after the fourth decade of life in muscle mass was only up to about 1% per year, which, tracks with this bar chart on the left. However, the loss in strength was up to 3% per year, and the loss in power was up to 4% per year. Right. And so that is why, I focus less on mass and more so on these quality parameters. And I say quality parameters really to encompass everything about strength and power and things like that. So I operationalize, muscle quality as the infiltration of fat within tissue for my purposes, right? We see this infiltration in this muscle. So you're looking at some staining with lipid oil, red O here. We see muscle on the left, which really has little, lipid staining. And then factors due to aging, disease, diet, inactivity increase the lipid infiltration within that muscle, right? And so that is termed myosteatosis in the literature, right? So myo for muscle, steatosis as fat. And so I operationalize muscle quality as myosteatosis, right? So that doesn't mean that that's the only thing that occurs within muscle. Muscle quality, like I said, is a really ambiguous term that's used to describe, a slew of structural changes that occur in muscle tissue at the tissue level that uncouples mass from function, right? And this includes, like I said, adipose infiltration, fibrous tissue infiltration, edema, necrosis, inflammatory infiltration, et cetera, right? At the cellular and molecular level, we're really, talking about aspects relating to mitochondrial function, which I'll talk here in a little bit. But for the purposes of this section and imaging, I really operationalize it as fat infiltration or myosteatosis. And again, this myosteatosis is a better predictor and aligns with poor outcomes much better than any measures of mass do. And so I mentioned previously and very briefly that I work with really fantastic individuals in the Department of Radiology that help me utilize some of these really fun and sophisticated toys that we have, right? And so we can actually, we have clinical measures that we can estimate muscle fat infiltration. So what you're looking at here is a cross-sectional CT at the, I think this is the 12th thoracic vertebrae, one of my studies. And we can, we have our traditional mass measurements where we can kind of semi-automatedly, we can quantify how much subcutaneous fat there on the picture on the right. We can look at muscle, right, from a mass perspective, but we can do things that are a lot more interesting, and we can create these fat distribution maps within muscle tissue. And so the way that CT works, CT measures, tissue attenuation or density by way of a number, a Hounsfield unit, right? And fat has has a specific density to it, right? And so we can actually then quantify all the muscle in an area. We can quantify then how much fat or intermuscular fat is within that muscle tissue. But then we can also look at these, these distribution of various densities, right? And we can look at low density muscle, normal density muscle, and even extremely low density muscle. And we can say something more about the muscle and does that lend to outcomes? Right. And so as more fat and lipid infiltrates muscle, right, you're going to see a reduced density. Okay. And we see this very often. Again, this has been documented well within aging, within clinical populations. But we can opportunistically analyze CT scans. Typically, you're not going to get a CT scan in the clinical setting for body composition assessment, right? But CT scans that are used for clinical purposes, we can opportunistically pluck those and do some interesting things with them. And maybe this is somewhere that some of you can go in your research as well. But for the past few years, I've been working with Perry Picard and John Garrett in the Department of Radiology, and they've really created and refined this AI-based machine learning CT segmentation software that, again, we can grab any CT series that we want. And in the matter of seconds, the software can analyze it for a slew of variables that are very meaningful to outcomes, right? And so we can look at attributes pertaining to bone density and bone microarchitecture. We can look at aortic calcium. We can quantify visceral subcutaneous fat, also muscle. We can also look at intermuscular fat as well. And then we can look at a number of different organs. We can look at liver density, kidney density, spleen density, those types of things, and volume along with that. And we can do that throughout the entire chest and abdomen region, right? And this has been well validated. Just to give you a little taste of, and this automated technology really allows us to scale. When in the old days, we used to take CT scans one by one and manually trace and quantify the amount of muscle and density of that. And that's just really laborious and it takes a long time. But now with the CT software, we have studies where, Perry did the study in 2022 where essentially, they looked at almost 10,000 outpatients undergoing routine colorectal cancer screening. Right. And what you're seeing here is Kaplan-Meier survival curves, which I like to look at often. And you can see that after 10 years, when they had follow-up data on these individuals, you can see that the hazard ratio of individuals that had myosetosis versus those who did not, right? They had almost a 4-fold increase in death at 10 years. Whereas if somebody has myopenia, right, which is low muscle strength, right? The hazard rate is still significant, very meaningful, but something that we think, if you missed that crazy animation, there it is again. But something that we think is very problematic in healthy aging is obesity. And although it is, right, we know that it's established, look at the hazard ratio in individuals that are going in for routine colorectal screening and follow up 10 years later in individuals with myosetosis versus obesity, right? And so myosetosis and fat infiltration in the tissue is always rising to the top of some of the most prognostic variables, including even when we include other very clinically relevant measures. And so this is, again, just the power of this automated CT technology. We can see that myosetosis predicts survival in almost 2,000 patients diagnosed with colorectal cancer. This is just simply looking at a univariate hazard ratio for death. And we can see that poor survival in patients with low muscle density, high aortic calcium, and low subcutaneous adipose tissue. And I think, when we're using the CT software, right, we can really broaden what we're interested in. When we can get all these measurements at the snap of the finger, we're interested in looking at a combination of these things. We're not just interested in muscle, right? We can look at all these different things as well. Because as we age and as we go throughout the disease, what I'm not talking about today is this really intricate inter-organ communication between various tissues, right? Specifically for my interest, I look at the communication between subcutaneous adipose tissue, visceral adipose tissue, and muscle, right? If we're seeing all these lipids show up in muscle, it makes sense that we'd want to look at some of the fat tissue, right? And so this software gives us the power to do that, right? And it's always very prognostic. In this same study, if we look at a multivariate ROC analysis, we can see that predictive values increase when body composition measures are used in combination. And so then if we're trying to create a model, right, a risk prediction model in clinical populations and have it be a parsimonious model, right, we're seeing that muscle Hounsfield unit or muscle density, what I said before, and subcutaneous adipose tissue area, and what I'm not showing later, density of subcutaneous adipose tissue is really, really prognostic and is more meaningful than a slew of other clinical measures. In the same study, we can then group together individuals that have, well, this is actually looking at 3 different Kaplan-Meier curves, and we can see the kind of separation in the line when somebody has the lowest quartile of muscle density versus the other quartiles, right? In the middle, individual that has the highest aortic calcium, how that's separated from all the other ones. And then on the far right, we can see subcutaneous adipose tissue area. At this point in time that these data came out, we did not have, the software was not capable of measuring subcutaneous adipose tissue density at that point in time. But when you're thinking about lipid shuttling in circulation and to other tissues, the density of subcutaneous adipose tissue changes, right? And we can measure that with CT and some other software that I'll show you, or imaging that I will show you later. But these things are all very prognostic. And then if we put multiple measures together, it can be really meaningful. So what we're seeing here on the left is that individuals with low muscle density and low subcutaneous adipose tissue had the worst survival. And what's really interesting in the measure on the right is now we're looking at individuals with low muscle density and high or low visceral adipose tissue. So we all know that, visceral adipose tissue, if we're thinking about cardiometabolic risk factors for poor outcomes and poor aging, this is not good, right? But what we're seeing here in this colorectal cancer cohort is that VAT, whether somebody has high VAT or low VAT, does not matter. All that matters is when we group them by their low muscle density, is what that is showing. It's really interesting stuff. But we can do this in a ton and we have done this in other populations. This is a study that I did that came out a few years ago, and we can see that myositosis is associated with reduced survival in 189 patients undergoing heart transplant. And so very simply, what we did is we took the pre-transplant or their staging CT exam, and we took an anatomical landmark at the aortic arch, and we then analyzed muscle, right? We can see in the middle column, we can see that if we measured muscle density at a very small region of interest in the pectoral muscle, we found that was prognostic. So in the year after transplant, individuals that had higher density or above the median, 89% survival, and those with low density, below the median, those individuals had 72% survival. And then when we further created these distribution maps and we looked at, well, how dense is that muscle? Individuals that had more low density muscle area, so more muscle that was infiltrated with fat, we found that was also prognostic. Those individuals stayed in the hospital much longer, okay? It's just, these studies underscore the importance of CT measured tissue density, right, beyond mass. And what I should mention in those previous slides, muscle area was never significantly prognostic. So, CT is fantastic. CT is ubiquitous within the clinical setting. I'm sure the clinicians on this call, you're ordering CT scans all the time. And that's really good for researchers, that we can then go back and grab these CT scans, again, like I said, opportunistically, and analyze them for all these different prognostic markers, right? These variables, and try to create risk prediction models, right? But it's still a relatively qualitative biomarker, meaning that, we're just measuring tissue density, right? We can't really measure a quantitative amount of lipid within that muscle, which is really important. And that brings me to, MR imaging, so magnetic resonance imaging. So, in collaboration with a mentor of mine, Scott Reeder here, he's now the chair in the Department of Radiology, we decided to utilize a sophisticated and quantitative MR sequence called chemical shift encoded proton density fat fraction, right? And this technique is capable of quantifying inter and extra myocellular lipids for total fat percentage in a given area, right? And what you're looking at is a measure of the liver, because Dr. Reeder and his group has validated this imaging technique for quantifying liver fat for the diagnosis of hepatic steatosis. So no longer do they have to do a biopsy. They can just analyze the entire volume of the liver and place ROIs wherever, analyze the entire volume, and come up with a % fat, right? And so that's what they did here, right? They just put, ROI in the liver, and here's your % fat, right? Well, we can do the exact same thing, right, in muscle. And that's what I wanted to do. I want to utilize this MR sequence as our reference for % fat within the tissue for myosetosis, right? We no longer, as we age, we all have this process going on. We all have this infiltration of fat within our tissue that kind of degrades our ability to function. But when does it become, what's the threshold where it becomes pathologic, right? We don't have that yet. And so we're trying to get to that point. And so this is a pilot study that I did a few years back. And this is at the mid-thigh in the rectus femoris, we measured % fat, right? So this is 1.42% fat. This is an older adult. And we also had their age-matched individual undergoing lung cancer, right? And those individuals had increased fat infiltration within that tissue, although it wasn't statistically powered It was a small sample, but we're utilizing these techniques to really try to say something very intricate about muscle pathology. So that ends the imaging portion. So I also, I like to add some kind of mechanistic and molecular insight into what I'm seeing and what I'm visualizing. And that brings us to the mitochondria, right? So when discussing muscle quality, we need to consider the workhorse and the functional unit of the muscle, right? The mitochondria. Okay. And so the major functional role of mitochondria is ATP generation, right? To perform work, and then also to maintain that tissue, to maintain muscle tissue. And this relies on coordinated activity of mitochondrial biogenesis, dynamics of fission and fusion, right? Proteostasis, mitophagy, so getting rid of dysfunctional mitochondria and protein units. And if there's a chink in any one of these processes, and I'm not going to admit I'm nowhere near an expert in any of this. This is a big overarching umbrella of work, very complicated. But the output of that, if there's a chink in any one of these processes, the output is going to be reduced ATP production, right? And so we can actually measure that, right? So mitochondrial function can be measured by respiration, and reduced mitochondrial respiration and ATP production is associated with increased myositosis, decreased strength, and functional performance. Okay. And so when we take biopsies from these individuals and we're seeing this reduced respiration, reduced ability to generate ATP, we're also seeing that being highly associated with the fat infiltration within the tissue. So this is more so from your reference, right? This is not anything that's all that new. It's getting, it's been done a really long time. This is a classical study by Kevin Short and Sri Nair out of Mayo Clinic back in the early 2000s, where they really wanted to describe the age-related mitochondrial changes, right? The dysfunction that we're seeing. So they performed a comprehensive study in aged humans from 18 up to, I think it was 75 or 80 years of age. And they found that there's a decline in skeletal muscle mitochondrial ATP production that occurs continuously across the adult lifespan. So not these discrete groups, continuously across the lifespan. And this is even after they controlled for lean mass, right? We're still seeing these decline in mitochondrial function. And this decline in mitochondrial function was also then associated with a decline in VO2 max, right, which is a very good predictor of early mortality due to functional status, right? And so we see the VO2 max decline with age and is also related to this, and sorry, the MAPR is the mitochondrial ATP production, right? And so kind of connecting all the dots from our mitochondrial dysfunction to our functional performance. And what they found interesting, they found that the changes were primarily due to the changes in, and actually, let me back up. In the left-hand side, this says A and B. And really what this is, you don't have to know that. Really what that is looking at is we can feed in different substrates. We can run different protocols to look at various aspects of mitochondrial dysfunction. And they ran two different protocols for the knowledge here. They ran one that was what I call carbohydrate driven and one that included fatty acids. And they found similar decline in the mitochondrial function. So I do this, right? So with the help of a colleague here at UW-Madison, a tremendous researcher, Dr. ADAM KUCHNIA, we will inspect, along with our imaging, mitochondrial dysfunction and aging using this high-resolution respirometry, or O2K, right, which is a picture right there. And what we can do is we can take permeabilized muscle fibers from the biopsies, or we can do isolated mitochondria, and we can throw in fatty acids into the chamber, or TCA cycle intermediates can be introduced, and we can then measure O2 flux as a surrogate of ATP production and the efficiency of that muscle to generate this, this dynamic process, right? And so, thinking back to the electron transport system and all your schooling and all the things that you haven't thought about in a long time, we run these various protocols to where we can then feed in, pyruvate, malate, glutamate. These are those kind of what I mentioned here are the TCA cycle intermediates. We can feed those in. We can kind of watch how those stimulate complex 1 of the electron transport system. We can then also provide ADP to the system, where we kind of gradually increase ADP, replicating a stressed environment. We can also look at various quality control, and if that membrane of the muscle is intact by looking at O2 flux when we provide cytochrome C. We can look at complex 2 by activation by feeding in succinate, which enters into the electron transport system right at complex 2. And then we can also look at various aspects relating to uncoupling and inhibition of complex 2 and 3 and things like that. And so you can get a really good sense of how well is that muscle functioning. And I'm interested in doing this alongside of my imaging within disease states as well. And so this is I just put up some data for you. I was kind of spewing out data the other day. And this is a study that we did looking at older adults. These are older, healthy adults living in Madison, and we did mitochondrial respiration. We found that it was reduced in older adults using carbohydrate-driven protocol. Now, again, this isn't earth-shattering. This was nothing that that hasn't been found before, right? When we split the group into above 50 and less than 50, and the reason why we did that is we start to see there's been a lot of research that shows at somewhere around 50 or 60 is when we really start to see a decline in function, right? And when we really start to see an increase in sarcopenia. And so when we split those individuals across all the entire protocol, we see, and through all the complexes, we see reduced respiration when we provide it with what we're calling our carbohydrate-driven protocol. And then when we switch gears a little bit, there's a lot of interest in the aging population about like this discrete switch in metabolism, right? To where we can utilize carbohydrate, maybe not, or where we can utilize fatty acid to drive ATP synthesis. So then we provided a fatty acid-driven protocol. And what we're seeing here, we're seeing a similar, we're seeing a decrease in respiration through all complexes of the electron transport system, but it's not significant. And that's interesting too, because again, if we're trying to hone in, there's some debate honing in on this discrete metabolic switch in older adults. And this is important because as we lose our glycolytic fibers and we become more prone to having this increase in type 1 fibers, which we see in aging, it would maybe be expected that there would be some fatty acid respiration preservation, right? Because we primarily have this type 1 fibers, but there's still a lot of work that needs to be done in this area. And so, with some of my limited time here, I kind of want to tie it together again with my colleague who wrote a really nice review article with ADAM KUCHNIA and Urinary a while back that just says, as we age, right, you're going to see, we become more sedentary, right? We have poor dietary practices. We see this decrease in mitochondrial function, right? We see a decrease in the volume of our mitochondria, our mass of mitochondria. We see a decrease in the quality through ATP production and its ability to function, right? Well, we also see a decrease in skeletal muscle volume, quality, and function. We don't exactly know if we're thinking about mitochondrial function and muscle quality. We don't know if the infiltration of lipids within the muscle is causing, the mitochondria to act poorly, or is it the dysfunctional mitochondria that's causing this increase and blow up in the lipid droplet within the muscle. And so there's a lot of work that still needs to be done there. But regardless, taking those two things together, we see decreased functional capacity, morbidity, increased healthcare costs that's just detrimental to an aging society. And just very briefly, I know that I'm running out of time here, but, what are the management strategies, right? And I said that unfortunately, there's no FDA-approved pharmacologic, which is really necessary to move this field forward. But really, the most well-known and most effective strategy is exercise, aerobic and strength training exercise. And that's been shown, exercise training can attenuate age-related production of reactive oxygen species, right? It can stimulate protein turnover. It can repair damaged proteins and dispose of those damaged proteins efficiently, right? And so exercise can really increase mitochondrial respiration through all those complexes, right? And improve mitochondrial function. That's been established. But I'd be remiss, I'm in the Department of Nutritional Sciences, right? What does nutrition do to this? And nutrition does play a very large role in this, but it seems to be complementary to the most effective, which is exercise, right? You'll see that. But unfortunately, most people, spend, U.S. adults in general spend about 60% of their total leisure time watching TV, right? Which is a problem. We just kind of need to move more. And I put this quote up here that I think is funny. And Neil Binkley, my mentor, has used this a few times. Whenever I get the urge to exercise, I lie down until the feeling passes away. And I think Mark Twain had it wrong. So I'll go ahead and end my talk now.
Thank you.